Okay, ladies and gentlemen, welcome, dear friends, to this lovely webinar of Dr. Christian Plaaß. It's a webinar that I would love also to give myself because this topic is so hot. You know, Lapidus Arthrodesis, it's a powerful tool in treating bunion deformities. And at the end, you should decide whether you want to do a modified or original Lapidus Arthrodesis. And I think nobody in the world can ask this question better than Christian can do, because he is so active in this area. So it's a great pleasure to have Christian Plaaß now also as assistant professor at the Diakovere Anastiv Orthopedic Department in Hanover, and he will present us, you know, the whole philosophy, the whole ideas, the whole science, and the whole tips and tricks behind this. So thank you, Christian, to giving us this wonderful lecture. And at the end, for everybody who are joining us, write your questions somewhere, and at the end, when Lucas is moderating then your questions, he will pass the questions to Christian, and Christian will answer all the questions. So Christian, is your podium. Thanks a lot, and stay safe, everybody around the world. Thank you.
Thank you, Victor, for the inviting words. It's a pleasure for me to talk again for Medartis. I think we had very outstanding lectures already in this series. And I would like to talk about the Lapidus Arthrodesis, modified or original. This preparation of this talk was really challenging because I had to rethink some of my beliefs. Here you see my disclosure. I'm a consultant from Medartis and also work together with some other companies. I see this webinar as a continuum of the previous webinars we had on hallux valgus already from the IBRA. You can also see them in the net on YouTube or on from the IBRA homepage. We had the first one on the rotational instability of the TMT1 joint, and we later on had the other battle between me and Jim Carmichael about osteotomies or arthrodesis for hallux valgus treatment. This is a slide you all probably know, the history of TMT1 arthrodesis started with Albrecht in 1911, who did the first TMT1 fusion in patients with hallux valgus, Morton with the concept of hypermobility, and so on. Until 1934, Lapidus first presented his series of patients with a midfoot fusion for hallux valgus, and this is what we refer for when we talk about TMT1 arthrodesis. This was paused for some years because some bad results due to insufficient hardware, and in 1986, Clark presented Hansen's series of TMT1 arthrodesis, which were later known as modified Lapidus procedures. When we look at the technique of the original Lapidus arthrodesis, we see up here, Lapidus denuded the cortex of the metatarsal 1 base and of the metatarsal 2, and also, of course, of the TMT1 joint, and fused these together. The modified Lapidus by Hansen later on included one leg screw through the TMT1 joint and the anti-rotation screw from the metatarsal into the cuneiforms. When you look at the literature nowadays, most authors understand the modified Lapidus arthrodesis as an isolated arthrodesis of the TMT1 joint, and this is what I will refer to later. So the original Lapidus or the Lapidus procedure will be in my talk an arthrodesis of the first of the medial column to the second column, and the modified Lapidus will be in pure arthrodesis of the TMT1 joint. Now the aims of the talk are: what is the rationale of intermetatarsal cuneiform fusion? What is the best technique for it? are there any differences in the outcome of a TMT1 fusion with and without intermetatarsal or cuneiform fusion, and which technique should we use? I prepared one poll at the beginning, and we will present the results at the end of the talk. So Lucas, could you please open up the poll? So you see here my questions I have for you. Do you do any Lapidus procedures? Do you only isolated TMT1 fusions? Do you do isolated TMT1 fusions and intermetatarsal cuneiform fusions in selected cases? Do you do them regularly, or do you always use them? Okay, we now have 25 from 140. Okay, so I think, Lucas, we stop it here and go on with the talk. Okay, so the questions we have when we talk about instability of the TMT1 or of the hallux valgus is there any instability of the medial column in patients with hallux valgus? And I think we can answer this. This has been discussed for years. The answer is yes, there is one in patients with hallux valgus. And the next question, in which planes the instability exists, is also answered by several publications. It's a three-dimensional instability. We see abduction, pronation, and dorsiflexion of the first ray. But what is most interesting for this talk is where is the instability localized? And there are several studies trying to answer this question. Especially weight-bearing CT or simulated weight-bearing CT gives some answers. There's one study showing that, that there's more mobility in the TMT1 joint in patients with hallux valgus, and as you see here, in all three dimensions. This is what we know. So more interesting is this study published in 2017. And this study shows that not also only the TMT1 joint, but also the TN joint, the NC1 joint, and as I said, the TMT1 joint have a higher mobility in patients with hallux valgus. So it's not only the TMT1 joint, but the whole medial column, which has a higher mobility. The open questions then are, is the hypermobility isolated to the medial column or to the whole longitudinal arch, and which structures stabilize it? And this was answered by the same group in another study, and they showed that the instability is between the cuneiform 1 and 2. So it is a pure instability of the medial column and not the longitudinal arch. So if we stabilize the medial arch to the second, to the cuneiform 2, we get rid of this excessive stability. Now, which structures stabilize the intercuneiform joints? And this is a biomechanical study we performed in our lab. It was founded also by the IBRA. And what we found, and I show you here some of the first results, is that the passive structures that stabilize the, between the medial column and the second and the lateral column are the intercuneiform ligaments. So if we want to stabilize it, we have to stabilize here the intercuneiform region. How can this be done? When you look at the history, there were some proposals to do a distal fixation, as shown here from a publication from Germany. Or this was another case we saw in our outpatient outpatient area. You see here a distal screw, and you see here the breakage of the second metatarsal, and this is a quite high risk of this if you do a distal fixation, and also you have a high risk of screw breakage if you use screws below 3.5 millimeters. When you do this with suture techniques, for example, with a tightrope or tension band, you also have a 25% complication rate. So distal fixations are not safe. What is better as a technique is proximal fixation. We know from anatomical studies that there's a low risk of damaging any relevant structures here. From biomechanical studies, we know that a two-screw construct as shown here is more stable than a two construct as shown here. Plate and screw is more stable than 3 screws. And intermetatarsal screw as used by most authors is more stable than a metatarsal cuneiform or intercuneiform screw. But there are also complications if you use them. You have an 8% rate of pull out of these intermetatarsal screws. You have a rate of 5.3% hallux varus, and you see about 8% of screw breakage in these studies. You also have other complications as seen in this patient. She had a distal fixation temporarily and had this union here, which made her a lot of pain, and we had to take it down. So besides the quite good results published, there's also, when you look on the long-term results, up to 16% recurrence rate in the original Lapidus technique. So it's not only depending on the intermetatarsal fusion. And there are studies out there showing that the stiffening of the midfoot is relevant if you fuse the medial column to the second column, because you lose your windlass mechanism and you prevent sagittal motion, and there's a higher risk of metatarsalgia in these patients. There are only few studies showing the long-term outcome and comparing the original and the modified techniques. Both show some loss of intermetatarsal correction, and both show some patients with recurrence. In some studies with the original techniques is even up to 16%, so it must be something else than just the intermetatarsal fixation. So how do we decide if we have to do an intermetatarsal arthrodesis or not? There's one proposal, and this is the hook test. This was done by several, but Fleming published this first. What they do is they prepare the joint, then you reposition the arthrodesis, and then you pull on the first ray and see if the intercuneiform space opens up, which is judged as positive if it opens up for more than 4 degrees. Then an intermetatarsal arthrodesis is performed, and in their studies they found 74% of patients with an instability. But there are some open questions to the study. It's not documented how much force was applied. We don't know anything about the prospective value of this technique. And what also we don't know if any of our patients develop an instability over the time. Nevertheless, this is the best technique we have at the moment to analyze for an proximal instability. Something else I wanted to show you, because this is a much discussed case in the internet, is down here. Here the author shows how he repositions the joint and after this fixation he does this hook test. And I think this is not a good technique, because you cannot be sure if you really stabilize the joint with this distal fixation with your arthrodesis right, or if it's just a temporary fixation here. So what is our own technique? I think you all know this classification published by Sandrock and Smith. integrating not only the horizontal but also the pronation deformity of the first ray. And this is how we do our decision on the kind of treatment we do. So especially we talk now about these cases here, about the patients with an increased intermetatarsal angle and pronation of the first metatarsal. So how we do it is we first do our distal soft tissue procedure, then we debride the TMT1 joint, and then we do the repositioning by a derotational move. I don't use fixed angles, but I use the congruency of the MTP1 joint to reposition the joint. You see it up here when you turn and take out the pronation of the first ray. You see here how I turn the hallux. You get a nice reposition of the first ray. You see that the round sign you see here vanishes, so with the sharp corner of the first metatarsal, and that the sesamoids are repositioned under the first metatarsal. When you look at it clinically, you see it down here. You see the K-wire showing the rotation about 20 degrees in this case, and how you can reposition by derotation your first metatarsal. And then you fix it after you're happy under fluoroscopy with your leg screw. Then I do the hook test, and I wanted to show you this case because it's a bit special. I did my reposition here, then I temporarily fixed it with a K-wire. Then I brought in a leg screw, and as you see here, I somehow didn't look close enough. But when I did my hook test, I was really astonished because the joint opened up quite a lot here. And then I noticed that the leg screw was not fully inserted. I put in the leg screw, and now you see with the hook test that the joint is completely stable. So it also depends on how you do your hook test and in which time of the operation you perform it, and that you have a stable construct here for your TMT1 fusion. And it also shows that you really test the intercuneiform stability and not the TMT1 stability. Here with more force, you see there nothing opens up here. When the hook test is negative, I like to take this plantar plate from Medartis because it has some advantage to the medial plate as shown here, but which you can also, of course, take if you like to. The advantages of the plantar plate I've shown in the other webinars are that you have less conflict with tibialis anterior tendon, as shown here with the medial plate. You see that these are often in conflict with the tibial anterior tendon. And when you have a plantar plate, you have less nerve and vessel damage, less tendon irritation, and a better soft tissue coverage, as shown here. You see the wool muscle of the abductor hallucis goes over the plate, so you don't have any issues here. Here another patient, again repositioning, then you do the hook test and you see how it opens up. Also the initial reposition was okay. You see here's still some subluxation, but this is sometimes difficult if you have a lot of instability here. And then we decided to do an intermetatarsal fusion. What we do here for preparation, we free here this area from soft tissue, drill both cortices and put in some bone graft from the pseudoexostosis, and then you see here how nicely you can compress this with an intermetatarsal screw. I think it's important that you don't do X-ray cosmetics with just a screw in here, because you can close any intermetatarsal gap with it, but that you really have a good reposition at the beginning, and then do this technique when you have and notice this intercuneiform instability. And here you see the clinical pictures to it. Our after treatment consists of partial weight bearing for 6 weeks in a walker. And our own series shows that we have intraoperative instability intercuneiform in about 8% of the patients. This is much lower than what the previous studies showed, but these are our numbers. I showed you that also depends on the technique, how you get, how much instabilities you get, but this is what we have. And Medartis and the IPRA all have a prospective study of this. I hope we can give you some results in the near future. Now I want to show you some cases. You see here a typical patient, 42 years old, female, typical hallux valgus position. You do a Lapidus procedure, a modified one. You see here, I think, a quite good correction of the intermetatarsal angle. But you see here already after 3 months, you see some opening up of the intercuneiform joint. And after half a year, you already see here a gap and a relapse of the hallux valgus. So this is one patient. This was before we learned about the intercuneiform instability, where an intercuneiform stabilization might have saved her from the relapse. Another case, also 60-year-old female, also typical hallux valgus deformity. We did Lapidus procedure, and you see, I don't have here the intraoperative pictures, but because they were on paper. But you see here already the first weight-bearing X-rays. You see how this instability from distal went on to proximal, and how this intercuneiform space goes up. And also you see here the instability in between the cuneiform joints. So this also would have been a patient we would have probably detected intraoperatively if we would have done the hook test already at this time. Here you see again the instability. It's not the bad reposition at the beginning, but it's the instability intercuneiform. Another case I wanted to show you just to make sure that the initial repositioning is the key. Just doing an intermetatarsal fusion doesn't help if you don't reposition the first frame. Then another patient with a contract hallux valgus. This is a male. You all know, or at least in our cases, males are always a kind of special when they have a hallux valgus. You see here again the intraoperative X-rays. You see the reposition. I would not have been so happy with it, and the colleague was happy, or I was happy. I don't know. I did it. We did the intermetatarsal screw, and the intermetatarsal room was closed. But you see here, due to the metatarsus adductors, hallux valgus relapse. The patient in this case is happy with it, but as a surgeon, I think you cannot be too happy with it. Another patient, 46-year-old female. This is a case I did myself. You see here, she had this instability. I brought into the screw. I think intraoperatively it looked okay, but already postoperatively, you see here the hallux varus, and this is something I would like to warn you of, because this intermetatarsal screw is really powerful. So if you over tighten it, you can end up with a hallux varus, as in this case. And you see here the screw loosened out, and the intercuneiform joint opened up a little, and this saved me. The patient still has some varus, but she is happy with it, and we didn't have to revise her. Another case, 43-year-old female, again, typical hallux valgus deformity. We did an original Lapidus Arthrodesis. It looks first good at the beginning, but the patient was not very happy with us. She had a severe pain on the third metatarsal. And when you look more closely, you see that the second metatarsal is high up in the air. The problem in her was that the intermetatarsal screw fixed the second, as you can see here, the second ray quite high up, and she got this transfer metatarsalgia. So it's not only that you have to watch out for the horizontal position, but also for the vertical position if you bring in this screw. So it's not that easy as it might look. With another case, 24-year-old nurse from the neighboring hospital. She had already 11 previous operations altogether, starting at the age of 14, including some infects with multi-resistant bacteria. First, she had just the removal of the pseudoexostosis, then she had an opening wedge osteotomy and additional Aiken osteotomy. She went on to Lapidus Arthrodesis. You see here, it's not very well repositioned then. Again, she was revised and then got this revision Lapidus Arthrodesis with some intercuneiform stabilization. And this is how she came to us. She developed pseudarthrosis intercuneiform, as shown here. She had severe pain here. She had this hallux valgus relapse. And what we did was another revision. We did an open wedge osteotomy of the first ray, distal derotation osteotomy, and an intercuneiform rearthrodesis. And now she's quite happy with the situation, but you see after 11 operations, and the key, I think, was the missing repositioning in all the previous operation. Another revision case, 29-year-old female, previous open wedge osteotomy, chevron osteotomy distal. We did here this Lapidus revision arthrodesis with intermetatarsal fusion, and you see here again a failure of the intermetatarsal fusion, which had to be revised with a bone from the pelvic and from the iliac crest, and 2 screws to fix it. This finally healed, but you see in my hands the intermetatarsal fusion is not without problems. Another case, 20-year TMT1 fusion with intermetatarsal arthrodesis. Oh, sorry, this is wrong slide. Here another case, a 46-year-old female. She had a hallux varus at the beginning, and again, it saved me that with hardware removal, the intercuneiform space opened up a little. You see here also we tried to get a fusion, again, no bony fusion. But in this case, it was really helpful because the hallux varus saved us. So now I want to start with a discussion or with a poll from the beginning. You see here the results. I hope you see them. Okay, now you see the results from the poll at the beginning. Most of you, about 50%, do only isolated TMT1 fusions. About 1/3 does, in some cases, intermetatarsal intercuneiform fusion. I think this is about the numbers we all in the technique we also do, and only 6% do an original Lapidus arthrodesis in all of the patients. Now, the questions now which would interest me is, will this talk influence your concept of Lapidus arthrodesis? I would like to ask Lucas to open up the second poll. And I'd like to ask you if this talk will change your way of treating. Okay, I think we can stop it here. Numbers are not changing anymore. So I'm quite happy that about nearly 90% of you will have some influence of this talk on your Lapidus Arthrodesis technique. I hope in the discussion later to see what you will change. Sorry. There. No. Yeah. Okay, to conclude, the modified Lapidus Arthrodesis is not a modified Lapidus Arthrodesis. You always have to look exactly in the literature what you get. The instability of the medial column includes the NC and TN joint, but it's still not clear when we have to treat it where. An intercuneiform metatarsal fusion reduces the mobility of the medial column. This has pros and cons. For me, especially when we talk about arthrodesis or osteotomies, I like to keep as much mobility as possible. The initial reposition is a key to success, and we don't have enough long-term data to really say which technique is superior and when and which technique you need to do an intermetatarsal fusion. So I thank you for your attention and like to start the discussion. Victor? Lucas, do you have some questions?
Hey, Christian, first from my side, really nice presentation. That was highly educational, and I'm very surprised about the last question you got. So first question from Sergio, is it possible to do a bilateral simultaneous surgery for the Lapidus?
This is a very good question. I don't like simultaneous surgery so much. I think with the new and better arthrodesis techniques with plantar plating, it's possible to have the patient full weight bearing. But my personal opinion is that they have more pain, longer rehabilitation. And so in my opinion, I prefer to do it 2 times.
Mm-hmm. Next question from Eric Ham. How often do you utilize the transfixation screw with the TMT1 dorsal medial plate?
Yeah, I reviewed all our cases, and it's about 8% of the cases where we do, after positive hook test, use the intermetatarsal screw.
Mm-hmm. The next question from Mohamed Shafi. How did you access the first ray hypermobility clinically?
That's also an excellent question. I think I have no final answer to. I think we all have our hands that you take the foot, dorsiflex it in the ankle, and then see the relative mobility of the first ray in the vertical area. If it gets up more than 1 centimeter, it's by consensus judged as unstable. But when you look, for example, for bandage test and so on, we don't use it regularly. So it depends on the surgeon's experience. I think it's no clear test how to do it. There's some studies showing that you can push between the first and the second column, but this is not standardized at the moment. So I think we don't have really good clinical tests for that.
Okay, we got many questions in now. Okay, next question from Wahi Seran. How do you prepare intermetatarsal space for fusion, and do you attempt to create bony fusion?
What we do is we debride the intermetatarsal area. We don't debride the intercuneiform area. We take out the soft tissues, we do drillings in the bones, and then we put in some bone from the metatarsal head, from the pseudoexostosis, and then put in the screw. Last week, we heard in the excellent talk from Lawrence Rubin that what he does always also add an intercuneiform fusion. He opens up the intercuneiform joint and debrides it there. Perhaps this is also an idea to do it. We didn't use that regularly till now.
Very good. Next question from Alexei Bark. How do you access the rotation of the first ray interoperatively?
Thank you, Alexei. There are several techniques out there how to reposition the joint. There's this technique from Emilio Wagner where you first measure the rotation, then you calculate how much you have to rotate, and then you do this exactly like this. I don't think we can measure it exactly now at the moment. So what I do, I use the joint congruency of the MTP1 joint. I dorsiflex the MTP1 and push the hallux dorsally, and then the metatarsal follows due to the joint congruency in the rotation. This is my technique, and I think it works quite well. When you change your technique from just transversal correction to derotational rotation, you will feel and learn how much nicer the joint moves after this derotational technique compared to just a transversal correction. And so I think this works quite well.
Okay, another question from Alexei. Did you ever experience the breakage of the transverse screw?
I've showed one case, and I think this is our only case where we had a breakage of the screw. It's a 4.0 screw we use, but this is the only breakage we had so far.
Another question from Ivan Matos. Do you have peri-arthrodesis, osteoarthritis, and transverse metatarsalgia?
Sorry, I didn't get this. Could you repeat, please?
Do you have peri-arthrodesis, osteoarthritis, and transfer metatarsalgia?
This also is an excellent question. When we talk about, I understand it like this: that you have osteoarthritis in the neighboring joints after TMT1 fusion, and we have two patients with an NC arthrodesis, which is non-symptomatic in both. Both have non-optimal reposition. Both are plantar flex in the TMT1 joint. And so this can be an issue, but I haven't seen any arthrosis in neighboring joints after TMT1 fusion if the reposition was correct. The other question was the transfer metatarsalgia. We stopped metatarsal osteotomies completely in patients with just transfer metatarsalgia when we do a Lapidus procedure, because we checked our series and we reoperated two patients due to persistent transfer metatarsalgia after hallux valgus correction, and of about 250 without with transfer metatarsalgia before correction of the hallux valgus. So we don't primarily operate on transfer metatarsalgia, and we don't have any so far after Lapidus arthrodesis, as far as I checked in our series.
Okay, then another question from Nathan Schwarz. What is your opinion about lapiplasty? Have you ever used that?
No, I don't. I have never used it. I think it's a good help, or it can be a good help. I think it's very cumbersome to use. It's a lot of steps, but the theory behind it is good. I personally, for me, I don't need it.
Okay. Do you release the fibular sesamoid ligament before reducing the IAM angle and performing your fixation?
I think this is something depending on the kind or the severity of hallux valgus your patients have. If you treat all your patients with a Lapidus procedure, as some authors do, you'll have a lot where you don't do too much soft tissue preparation first. Our patients come quite late with high intermetatarsal angles, and these are the ones we treat with the Lapidus procedures. And there we often have contract distal soft tissues, and there we do a staged release. I first release always the lateral capsule with a McGlamory at the beginning, and if we don't get the joint loose, then I also release the lateral sesamoid ligament. But I do this in the stage procedure, and I only do this if it's necessary, and I do this transarticular.
Okay. Then from Paulo Ferraro, do you ever correct the DMAA?
Since we do a derotational reposition, I did not have to do, or I didn't do any DMAA corrections in acquired adult hallux valgus. I think we have to differentiate what kind of hallux valgus we have. If you have a young patient with an adolescent hallux valgus or juvenile hallux valgus, you sometimes have dysplasia of the really dysplasia of the MTP1, and then you have to do a DMAA correction. If you have let's call it normal and a metatarsal and just an hallux valgus caused by instability, I think when you do a derotational repositioning, you don't have to correct the DMAA. And we know from several studies now that the DMAA we see on the X-ray is a direct function of the rotation of the metatarsal. So it really depends. If you have an dysplasia of the joint, you have to do it. If not, you don't have to do it.
Okay, very good. Then next question from Anis. Do you need in some complex cases to accompany Lapidus Arthrodesis with a proximal osteotomy, for example, chevron?
It means distal osteotomy. In some revision cases, I had to do this because of scarring, or because I had to correct a previous chevron osteotomy. Yes, it can be necessary. In primary cases, no, I don't think so, no.
Okay. Then from Ferros Valley, what is the non-union rate in your experience with Lapidus?
When you look in the literature, it's about between 0 and 6%, and I think we are in those years now by 3%.
Perfect. Then another question from Mohamed Safi. Which is the right direction doing the intermetatarsal fusion transfer screw? A retrograde direction with the screw position?
Yeah, we use normally the medial plate from Medartis, and it really nicely guides you in the basis, in the base of the second metatarsal. But this is a technique we use. There are other techniques out there going into the in the cuneiform, in the second cuneiform. I think I cannot finally answer what is the optimal technique, but our technique is an intermetatarsal screw from medial to lateral. And this is nicely guided when you use this special plate from Medartis. This really helps you to get in the right area of the base of the second metatarsal. If you look also on the right orientation, as I showed you this case with the malpositioned screw, you have to look for the vertical position of the heads too, but then if you do this, you will nicely guided by the plate.
Okay. The next question from Faisal. Do you add Aiken osteotomies frequently?
Yeah, we do frequent Aiken osteotomies in nearly all of our patients.
Okay.
About 90%.
Okay, then another question from Arrow. How do you prevent hallux varus after original Lapidus or modified Lapidus procedures?
Yeah, I think when I personally started Lapidus Arthrodesis, I had to fight to get enough correction to get another relapse. When we move to the derotational technique, it's more that you fight not to get a hallux varus, and in some cases it's really necessary to take back your derotation a little bit to have a straight toe. As I showed you, we had some issues with hallux varus when we start with the intermetatarsal screw, because this really fixes the position you bring it in, and as this is, you can bring it in as a leg screw, you have really to be careful not to over tighten it, and to get a physiological intermetatarsal angle, we try to get not to below 4 degrees, 4 to 6 degrees.
All right. Then another question from Victor. In concomitant metatarsalgia 2 and 3, do you do a vial osteotomy 2 and 3, or do you wait whether the load of the first ray gets normal?
Yeah, we normally wait. If the MTP joints don't have a pathology itself, so if there's no subluxation, if there's no rupture of the plantar plate, we normally wait if the pain vanishes after stabilizing of the first ray. And as I said, we reoperated about 2 or 3 patients of 200 in the last years for persistent transfer metatarsalgia.
Okay. Then next question from Mohamed Safi. How do you manage failed Lapidus arthrodesis?
I think we can do a talk about this and talk about this in the next hours. It depends on where the deformity is. If you have residual rotational issues, if you have an enlarged intermetatarsal angle, if you have an arthritis intercuneiform, if you have an intercuneiform instability. So you really have to look at every case and analyze it where the problem really is. So you can't say I do it this or this way.
Okay, super. Okay, perfect. One last final question. I think then we got enough questions. How often and what do you do in distal soft tissue issues? MTP joint fusions, MTP1 joint fusions? It was from Sergio.
Distal. I don't know exactly what's the question with that. What we distal soft tissue issues. I don't understand the question really. If you have bad soft tissues, I think first metatarsal fusion is always a good option. If you have an infection there or open bursa, we try to close it first, and then when it's closed, you do a fusion of the MTP1.
Okay, he was just writing lateral capsule conjoint tendon. Okay.
Well, Christian, thanks a lot. It was a fantastic performance as usual. And you see in the questions, this was amazing how much you stimulated the people. Thank you for helping us in this decision making to improve patients' satisfaction. And also here again, I thank Medartis to helping us to put these webinars together, which are really an excellent education beside our life in clinics and beside this corona pandemic situation worldwide. Thanks a lot to Hanover, Christian, and to everybody. Thanks for being here.
Thank you for the invitation. Thanks to Medartis, and thanks for your patience and listening.
Perfect. Also, thanks from my side. The webinar is recorded and will be uploaded on the Medartis website within the next week. Thanks all for your attention and have a great evening or a great day. Bye-bye.
Bye.